Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey friends, welcome back to another episode of the Healing Pain Podcast. I am your host, Dr. Joe Tatta. As always, it's a pleasure to be spending this time with you. On this week's episode, we're discussing how to build a stepped care model for the treatment and intervention of chronic pain. The stepped care model for chronic pain originated in the VA health system and has been used in a number of other places. This model prioritizes the role of primary care providers in optimizing pharmacological management, as well as the timely and equitable access to patient-centered, evidence-based, non-pharmacologic approaches. Joining us this week to discuss this model is Dr. Matthew Bair. Dr. Bair's principal research focuses on chronic pain and psychological comorbidity and developing strategies to improve pain management in the primary care setting. He has a strong background in conducting clinical trials and developing and testing interventions that combine pharmacologic and non-pharmacologic treatments, and his funded work often contrasts pharmacological and behavioral approaches for pain management. He has served on several national Veterans Affairs committees related to improving pain management, as well as the Clinical Practice Guideline Committee at the American Pain Society. Dr. Bair currently serves as editorial board member for Pain Medicine and the Journal of General Internal Medicine. On today's episode, you'll learn all about a stepped care model for chronic pain, the effectiveness of a stepped care model, and the impact of chronic pain amongst veteran populations. Okay, without further ado, let's begin and let's meet Dr. Matthew Bair and learn about a stepped care model for chronic pain. Hi there, Dr. Bair. Thanks for joining us this week on the Healing Pain Podcast.
Great. Thank you, Joe. Thank you for having me.
I'm excited to talk to you about your work, stepped care model for pain management. It's been out there for a while. I know the professionals in the VA system probably have heard of it. Maybe even they're currently using it or they're aware of it. Once we move outside the VA system, as you know, things start to thin out a little bit because we're in a big country and there's lots of different systems and the research isn't always applied. But most of your work, I mean, you work for the VA, you work in the VA system, and you're intimately connected to this, global, but of course, national challenge that we have of chronic pain. Just give us your own perspective, of working in the VA. How big is this problem and what is this looking like from working inside the VA system?
Sure. So just briefly, I'm a general internist by training. So I practice in a primary care setting, general medicine clinic in the VA. I've been doing that for 18 years now. Prior to practicing in the VA, I was in the Army. I was an Army physician. So I was in the Department of Defense for 7 years as well. So I have a military background in terms of military medicine. And, over the years in the DOD and moving on to the VA, certainly seeing how big a problem chronic pain is among veterans. In fact, if you look at epidemiologic studies, chronic pain is even more common in veterans than it is in the general population. And some reports, veterans report, chronic pain in a primary care setting up to, 50%. And then even more common in women veterans, as high as 75% report pain. So it is a very common problem. Of course, it's very costly. It's disabling, as we know. And unfortunately, it looks like the incidence of pain, especially low back pain, is actually increasing among veterans. So there's some studies that are showing increasing incidence of chronic pain. So it is a big problem. It's again common, costly. It's disabling, and unfortunately, it's comorbid with a lot of other mental health conditions, which complicate its management and make it more difficult to treat in veterans.
Yeah, complicated, complex, and costly is often the things we're kind of rotating around here on this podcast and the things that we're looking at with regard to the treatment of pain. I know you lead a team of researchers, colleagues that are helping you look at this. How have you tried to address chronic pain in the veteran populations that you've treated?
Yeah, well, it's really been a team approach, and I've been fortunate to be part of a great team over the last 15 plus years. And we've tried to address it by conducting clinical and health services research. We've been involved in more than 10, between 10 and 15 clinical trials, really trying to fill some of the evidence-based gaps to more effectively manage chronic pain. Most of our trials have focused on patients in the primary care setting. Most of our trials have focused on addressing chronic musculoskeletal pain. So we've done trials focused on chronic low back pain, osteoarthritis-related pain, neck pain, and fibromyalgia. And we've done a variety of different trials. We've really tried to develop and test interventions that combine pharmacologic and non-pharmacologic treatments, and really finding optimal combinations of pharmacologic, non-pharmacologic. More recently, I've moved into studies looking at complementary and integrative health treatments, particularly yoga and massage for chronic pain conditions. And so, recognizing that, the complexity of, as you mentioned, Joe, the complexity of chronic pain, that we need to find combinations of treatment to best help our patients and our veterans with chronic pain.
Yeah, combination of treatments, that's important. Oftentimes people don't, and when I invite people on, oftentimes they're researchers who are studying just one thing, because obviously, in research, when you can isolate one intervention, then you can see how it works. But we're all moving toward integrating the best evidence. How can we find, for the person in our office or in our clinic, what is the right combination of mostly active interventions that are going to help people overcome both the physical as well as the psychological and emotional challenges that they're seeing? You've been working on this for a while. Where in this evolution did the stepped care model come from? And if people aren't familiar with the stepped care model, they can just Google stepped care model VA system, and your paper and probably an image will come up of that step model. But where did the idea for that come from? And can you explain what the step model is for the clinicians who are listening out there?
Yeah, so we learned about step care model for pain from a couple early researchers in the area, one being Chuck Engel, who was in the Department of Defense initially at Walter Reed, and then had moved on to University of Washington, and Michael von Korf. So Chuck Engel had discussed step care treatment in the context of not pain, but Persian Gulf War syndrome. Mm-hmm. Now, Michael von Korf had studied step care intervention in the context of low back pain. So we learned significantly from Drs. Engel and von Korf. And I think step care can mean different things for different people. We've used it at sort of a micro, at sort of an intervention level that one way is to look at a step care intervention. So we've tested step care interventions, and we've defined that as sort of, starting with a lower intensity, less costly treatment, say in an early step, step one, for example, and then stepping up to more intensive, potentially more costly, complex treatments in subsequent steps, step two or step three if needed. And the stepping up is often guided by, when a patient may not respond adequately, they didn't respond well. So poor responders might step up to, step two or step three. In a larger level, if you're talking about the Veterans Health Administration, so at a health system level, you're absolutely right. The VA has, ever since 2009, have really disseminated their step care model for pain management. And it's really been at a sort of a roadmap for us to really guide our choice of treatments and our intensity of treatments, really starting at a foundational level with pain education, self-care, self-management. And then step one would be sort of primary care treatments. Step two would be specialty care treatments. And step three is really, sort of multidisciplinary tertiary pain centers that the VA has. And with each step, there's, it's increased intensity, complexity of the treatments, which aligns with the complexity of the patients or potentially the refractoriness that those patients have experienced due to previous pain treatments. So different, step care at a health system level, and then step care at a intervention level.
So tell us again, there are 3 steps or 4 steps to that process?
Yeah. There's kind of 4 steps. There's sort of a foundation that we believe that, we want to empower veterans, not only veterans, but, we know how chronic pain affects families as well, families and caregivers. So we want to equip patients, caregivers, and family members with, self-care strategies and education about pain. So that's sort of the foundation step. Step 1 is really primary care-based treatments. Or what a primary care provider can fairly easily either co-located with a behavioral specialist or psychologist or even physical therapist in primary care and easily refer. Step 2 is more specialty treatment, sort of maybe a pain clinic, a multidisciplinary pain clinic. And then step 3 is more tertiary pain centers.
Mm. It also sounds like as the steps increase, it's appropriate with the complexity of the case, and it probably also is in line with cost as well, I'm assuming.
Yes. Yeah.
Cost is a factor in the treatment of chronic pain because it can be costly to, the typical thing that you hear is multidisciplinary, interdisciplinary treatment is the quote unquote gold standard, although I have challenges with that on a couple of different levels, but multidisciplinary care is very costly.
Absolutely.
Yeah,
that's absolutely. And I think that's one of the reasons we've, multidisciplinary pain centers and clinics have, unfortunately been a dying breed. I feel so fortunate to work in the VA system because we don't have some of those cost constraints that outside the VA does.
Yeah.
So I don't worry about the costs as much. I don't have to pay attention to that as some of my colleagues outside the VA really like you need to pay attention to. But you're absolutely right that with increasing complexity treatment, that often is associated with fairly significant costs associated with it.
Yeah. Just on that lower level.
Yeah.
It's not a level that we talk about a lot, but you're talking about that lower level or services, outreach, education, if you will, for the families, loved ones, the community, if you will, of veterans. And that's important because we know the social aspects of their social support for someone, that community support can really help drive outcomes in a really positive way. But also that step to me seems critical because if we can figure out ways to disseminate that step on a larger scale, then it really starts to permeate just to the general public outside the VA, which could be really impactful for not only chronic pain, but other chronic health conditions, since chronic pain has so many overlaps. Mm-hmm. What does that look like, that first level? How does that in real life practice? What does that look like?
Yeah, great question. So what does that look like? I mean, what I can share is, what I try and do as a clinician. I certainly recognize that chronic pain affects not only the patient before me, but it affects the spouse or significant others. And so I often encourage, when we're discussing chronic pain treatments, that the spouse or significant others, adult children or siblings, be involved in those discussions. So we are all, part of that team. We're all working on this together. And part of that, I feel a major role of mine is to be an educator, to educate my patients and caregivers and family members. So that's just one way. That's not a very, that's one patient at a time. That's not a broad effort, but there's broader efforts. So often the VA has implemented things called pain schools or group visits, primarily focus on, pain education and where the patient certainly is involved, but the caregivers and family members are involved. So that's a little broader reach. I think even broader, and I think was implied, which I'm very intrigued by, is, how can we really make even a broader impact? And where I'm talking about is moving towards a public health campaign where we can really transform how the general population views chronic pain. And, in learning from how the tobacco cessation groups and advocacy groups did those public health campaigns, or some of the, I guess, opiate, anti-opiate groups, I guess, are talking, we need safer treatments for chronic pain, and how they have combated through public health and public health campaigns. If we can do that more broadly and in chronic pain, I think we might have a greater impact and sort of transform how chronic pain is viewed.
Yeah, I really like that step, because that's where a lot of the advocacy work is done. And advocacy work is important. People look at it just as like a, only for not-for-profit organizations. And I'm like, no, advocacy has layers in almost every part of healthcare. And people ask me, why did you start a podcast? And I'm like, well, like literally every week, it's like a 1-hour public service announcement about safe and effective ways to treat pain. And there's not too many of that we need more of that out there, basically. So that first level, I really appreciate it in that model. In that model, of course, the practitioners, the kind of pain geeks and pain nerds are going to want to know, does this model actually work? What are the outcomes? All the things we're talking about, when you put it into real life, is it fruitful, so to speak?
Yeah. Before I answer that, Joe, I just want to commend you for all that you do and your podcasts, and that's a great. I absolutely love your podcast, and I just commend you for the work you're doing. So, please keep it up.
Thank you.
To answer your question about, what about step care? Is it effective? And the short answer is yes. We found it to be effective, and I can highlight specific clinical trials, but generally we have seen clinically significant improvement on pain intensity, pain related function over the duration of our trials, which are anywhere from 9 to 12 months. We're finding numbers needed to treat relatively small, from 5 to 12. So number needed to treat to obtain a clinically significant improvement in pain, which is generally a 30% improvement, saying pain severity or pain interference. But we've also shown some improvement on other important outcomes, and those outcomes such as quality of life and depression and anxiety and sleep, which we know are common. So we have seen, improvements from step care interventions, and they've generally involved a model that's included several components. And one is some sort of decision support, which guides the treating clinicians. It also generally involves some algorithm-guided medication management. So we've either used studies looking at patients with pain and depression, where we've had an algorithm of antidepressant use that's sort of guided treatment and treatment to goal to reduce depressive symptoms as well as pain. We've used analgesic algorithms to guide treatment. And we've, really done some proactive monitoring with the use of care managers. And I think care managers have been critical. And we've often used nurse care managers to help with that follow-up, that monitoring of treatment response, any side effects that they might be experiencing from the treatment. It doesn't have to be a nurse, a care manager. We've also used pharmacy care managers, psychologist care managers, or clinical social workers. And so those are generally, we found there's 3 trials that we've, looked at using step care, and I can talk more about that if interested. But overall, we found that step care interventions have been effective on important pain outcomes.
Those algorithms are interesting because you mentioned depression, right? And I guess you primarily using antidepressants for that, it sounds like.
Yeah.
And then analgesic treatment of some sort. Looking at that data, I don't know if you can speak about this specifically. Do you find that one stands out more than the other? Because they're, obviously medication has a place in chronic pain management for reducing pain. And yes, when you reduce pain, some other aspects do get better. The same can be said for depression, actually. It's a huge problem in chronic pain. Right. One of the major psychosocial components that all of us kind of struggle with. Are any one of those two more beneficial than the other?
Yeah, great question. From our studies, we can't tell. And you alluded to it earlier. When you do combination therapies, one of the challenges is what is the most active ingredient of that? So we've done a step care intervention where one of our trials was called SCAMP, and we focused on primary care patients with chronic pain and depression. In step one, we used a antidepressant guided algorithm in step one. So that went along for 12 weeks. And then step two, participants received a pain self-management program, which was focused on, goal setting and pain specific exercise and, relaxation techniques, some CB, cognitive behavioral therapy type strategies. Mm-hmm. What we could not tell is which of those steps was it the antidepressants or was it the pain self-management program that was most effective. What we did see in the end is that depression improved more than pain. We had significant, large effects on depression, but more moderate or modest effects on pain. We wonder if we would have provided an analgesic algorithm in addition to some of the pain self-management strategies that we provided, would that have added more benefit on pain? And that's what we're considering now. I think we need to address both the pain as well as sort of the psychological comorbidities. So,
was there a particular analgesic that you were using in that? Or is it an opioid?
Yeah, in our studies, we haven't focused on one particular antidepressant or one particular analgesic. We've started with let's just talk about analgesics. We've started in our algorithm with simple analgesics. So acetaminophen being first choice, second choice being our non-steroidal anti-inflammatories orally. So naproxen being generally used first, ibuprofen, but we might use other non-steroidals. We certainly will apply topical non-steroidals as an important component of that early algorithmic steps for analgesic management. After those early steps, then we move into, depending on the pain condition, might move into skeletal muscle relaxants, such as cyclobenzaprine or tricyclic antidepressants for pain effects, as well as some sleep aid as well. We might work into the next step into the gabapentinoids, the gabapentin, and the pregabalin. Then we might work into the SNRIs, such as venlafaxine or duloxetine. And then we in the past, we had worked on some opiate management as well. So we might have started in refractory patients to a dose of, or some doses of tramadol. Mm-hmm. We've done a study in the past where all our patients had low back pain and they were on opiates at the beginning. And so we were really seeing if we could use a more optimal management of their analgesics, really focusing on the non-opiate analgesics first, but we did make some adjustments to their opiate management in that study. That study was called Cameo. So it wasn't really focused necessarily on step care, but it was an algorithmic-based management of their low back pain using primarily non-opiate analgesics.
Great, lots of great information there. It doesn't surprise me that pain in most of those studies didn't change a lot or change less. Oftentimes we see that depression has to go down first, physical function has to increase, other factors change, then down the line, pain changes. So it's interesting, the more I do this work, not that pain isn't important, but sometimes tracking it is not probably what we should be tracking in the initial phases of things. But I think that depression piece is really an important part there. When we're talking about your research particularly, but other studies as well have been similar to some of what we're talking about. In general, pain research has minimal to moderate outcomes. And, good research, we really want like kind of moderate to maximal outcomes. We want to see like an impact, right? That's why we're doing the work we're doing. We want to impact people's lives, their health, et cetera, et cetera. Why, even with all the great minds and research we have going on, we're still kind of at this kind of skirting on this moderate level?
Yeah, I wish I had a great answer. I mean, my thoughts on that. Are the simple acknowledgement that chronic pain is difficult to treat. It is difficult if our metrics are improving pain severity and function. I think improving function is a very difficult metric to attain. In many other chronic diseases, and I think we need to focus, sort of address chronic pain like a chronic disease. In other chronic diseases, hypertension, hyperlipidemia, diabetes, usually the outcomes are not, functional improvement. So one, I think in pain trials, our metrics are difficult to achieve. And just, the acknowledgement that pain is hard to treat, hard to improve on those metrics. I think the other thing is, I've alluded to it. I think we need, as pain clinical trialists and pain clinicians, we need to do a better job of addressing the comorbidities. And so treating comorbidities concomitantly, and those comorbidities, as you brought up here, Joe, is, depression being a huge one. Often that's overlaid with some anxiety. Often that's overlaid with sleep problems, which we know can exacerbate the pain experience. Working in a VA healthcare system, I'm attuned to PTSD and the complexity of PTSD management. And then you also have issues of substance use disorder, whether it's alcohol use disorders or opioid use disorders or other illicit drugs, which often overlap and complicate management. So I think we need treatment models and interventions where we address those we can't only focus on pain, I guess is my main point, that we need to try and focus on the broader experience, which often is psychological comorbidities.
Mm-hmm. The other aspect there are nutrition-related metabolic comorbidities, which are, so common in the United States of America that I'm sure are present in the VA every day.
Absolutely. That's such a ripe area. I'm glad I know not very much about that area, but I think that is a ripe area for future research and real potential there.
What direction would you like to see your research and your group go in now that, you have this STEP model, I know it's being used in the VA. Have people outside the VA reached out to you and said, can you come lecture to us or talk to us about how to implement this into, just your average hospital, let's say?
Yeah, we have been invited to do that. Thankfully, some opportunities overseas in Germany, especially opportunities in the Kaiser healthcare system and some other mainly academic programs. So I think some of the challenges are what you address is some of the implementation challenges. We've shown some, effectiveness, but that, as we know, effectiveness in a clinical trial doesn't necessarily mean it's an effective in a clinical setting. And so I think there's still some real implementation challenges. And I think implementation research and understanding what facilitates implementation of these types of models is an important next step for our research. What are some of the facilitators as well? Some of the barriers, what are some of the facilitators? I'm particularly interested in novel treatments. As a general internist, primary care doctor, I want, more tools, the better in my toolkit to offer patients, because we know that patients need, tailoring, and some patients just won't respond to certain treatments. So we need a lot of trial and error. So I'm interested in novel treatments. I'm interested in, finding the right combination of treatments and potentially the right sequencing of treatments. Is one treatment, should we be starting with a certain treatment and then moving to another treatment in a more effective sequence of treatment, with the goal of trying to improve treatment effects. And so those are a couple of my areas for research in the future.
Yeah, because it's interesting what you're saying, because the research is pointing toward a mix, as you mentioned, a mix of interventions help people. Mm-hmm. But what we don't know is what intensity do we need of each intervention, and when in the course of care should that be implemented, continued or discontinued, and as you mentioned, there could be comorbidities which influence all of those.
Right.
Yeah.
Right.
Definitely algorithms come to mind about trying to solve some of those complex cases. And the VA has shared data where most other systems really don't have shared data to leverage.
Yeah, I mean, the other thing, when you have large data sets like that an integrated healthcare system has, it does provide other research opportunities for comparative effectiveness and looking at costs of care and healthcare utilization. Those are really important issues to look at. And I think the VA, because of its data system, does provide that. And, we have upwards of 5 million patients within our system. So that's a large number. And, certainly not everyone has pain, but, if you say 50% have pain, that's still over, 2 million veterans have pain that are seeking care in our healthcare system. So that gives us some real opportunities to do really powerful comparative effectiveness research as well.
Well, I hope everyone checks out your research on the stepped model of pain care. Again, you can find it online just by Googling step model for pain management in veterans, and it'll pop up. Dr. Bair, if people want to follow you, get in touch with you, reach out to you, how can they reach out to you and follow your work?
Yeah, I'm happy to talk with anyone. I love talking about pain research. Probably the simplest is simply email me. And my email is mbair@iu.edu. I'm on Twitter, but I'm not an active contributor to Twitter. But so probably just email me would be the best way. And I'm happy to talk with anyone by email or set up a short phone conversation. And always happy to talk about work we're doing and if I can help others do the same work.
So that email address will be on the show notes because everything is transcribed here at the Integrative Pain Science Institute. So you can find Dr. Bair's email address there. You can probably also just Google Matthew J. Bair, MD, and it'll probably show up there, but you can find it on the show notes and we can always connect you with him if need be. At the end of every podcast, I ask you to share this with your friends, family, and colleagues that are interested in the safe and effective management of pain, specifically in this case, a step care model, which can be really influential for large systems that are looking to decrease costs and increase the effectiveness for chronic pain. I'm Dr. Joe Tatta, and I'll see you next week. Thanks for joining us.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit integrativepainscienceinstitute.com. That's Integrative Pain Science Institute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.